Welcome. Sometimes in neuropathology, you come across a case that's a real puzzle. Today, we're going to play detective and try to solve one of those puzzles. We're diving deep into a rare and pretty fascinating brain tumor.
And the whole mystery really boils down to this one question. What on earth happens when two totally different kinds of brain cells, we're talking a glial cell, which is part of the support system, and a neuron, which does the signaling, what happens when they decide to team up and grow into a single tumor? It's a biological riddle, for sure, and the answer is what we're here to talk about.
So, meet our culprit, the papillary glioneuronal tumor, or PGNT for short. Now, just looking at it under a microscope, you can tell it's complicated. And that's because it's defined by this incredible dual identity, what pathologists call a biphasic architecture. It's almost like two different worlds decided to exist in the very same spot.
Okay, so to really get our heads around this thing, we've got to start with the fundamentals. Let's build our case file from the ground up, piece by piece. Every good investigation needs a plan, right? Well, this gives us our roadmap. There are really three key clues we need to follow to crack this case. First, the fact that it's a low-grade tumor. Second, that super unique biphasic architecture we just mentioned. And third, a definitive genetic fingerprint. So let's dig into each one. All right, every clinical mystery starts with a patient. So who typically gets this kind of tumor, and how does it first decide to show up?
Well, if we look at the case file for PGNT, a pretty clear picture emerges. First off, these things are incredibly rare. They usually pop up in young adults, with the median age being right around 16 years old. It doesn't seem to prefer one gender over the other, and the classic symptoms? Things like headaches or seizures, which are really just caused by the tumor taking up space. But, sometimes they're just found by accident during a scan for something else entirely.
And just like in any investigation, location is everything. This is kind of like the scene of the crime. PGNT has a very strong preference for where it sets up shop. It's almost always in the upper part of the brain, the supratentorial region, and it really loves the temporal and frontal lobes. We also see it a lot right next to the ventricles. Those are the fluid-filled spaces deep inside the brain. Okay, so we've got our patient profile, we know the location. Now it's time to zoom in, way in. We're going from the big picture all the way down to the microscopic level to see what this thing is really made of. So, after a surgeon removes the tumor, we get our first physical clues. The lesion itself is usually really well defined. It has clear borders, which is almost always a good sign. It can be a bit of a mix, sometimes solid, sometimes with fluid-filled or cystic parts, and you might even see little bits of calcium or signs of old bleeding inside. But this is where it gets really unique. This is that core concept, the biphasic blueprint. I want you to imagine a city that has two completely different neighborhoods built right up against each other. One neighborhood is made of glial cells that form these really distinct structures, and the other neighborhood? That's made of neuronal cells, and they fill in all the empty spaces. Let's break that down even more. Look here on the left. That's the glial component. See how the cells line up around the blood vessels? They create these beautiful, almost flower-like patterns that we call pseudopapillae. Now look to the right. That's the second component. These clusters of very uniform-looking neuronal cells, just neatly tucked into the spaces between all those glial structures. This table really lays it all out, nice and clear. So you've got the glial part, with its small, cuboidal cells wrapped around these hardened blood vessels. Then you have the neuronal part, with its uniform cells hanging out in what's called a neuropil background. That's just a dense network of nerve fibers. And here's the kicker. They stain differently. We use a stain called GFAP for the glial cells and another one called synaptophysin for the neuronal cells. And if you weren't convinced yet, check this out. This is the definitive proof. This technique, called immunohistochemistry, is like using molecular highlighters. On the left, that brown GFAP stain proves, without a doubt, that those pseudopapillary structures are glial. Then on the right, the synaptophysin stain lights up only the neuronal cells in between. It's just a beautiful, color-coded confirmation of the tumor's split personality. So we've seen the tumor's strange structure, but what actually causes it? To figure that out, we have to go even deeper, past the microscope all the way into the DNA itself. We're looking for the genetic smoking gun. And here it is. The origin of the PGNT is a very specific genetic accident. It all starts when a piece of chromosome 9 and a piece of chromosome 17 literally break off and swap places.
This swap creates a brand new mashed up gene, and this new fusion gene is basically stuck in the on position, constantly telling the cells to grow. It's this one single event that acts like a master switch, creating this whole bizarre biphasic tumor.
Okay, so we have all our evidence now. We have the patient profile, the tumor's location, that unique two-part structure, and the genetic fingerprint. It's time to put all the pieces together to make the final diagnosis and, most importantly, talk about the prognosis. You know, in pathology, what you don't see is often just as important as what you do see. And PGNTs are critically missing all the bad stuff. You don't see necrosis, which is widespread cell death. You don't see the chaotic growth of new blood vessels. You don't see any of the classic features of a more aggressive, high-grade tumor. And that's absolutely key. And all of those clues, especially the missing ones, lead us right here to the single most important takeaway for any patient and their family. The prognosis is favorable. So, because of its nice, clean borders and the complete lack of those aggressive features we talked about, the PGNT is classified as a WHO grade 1 tumor. That's the lowest, most benign grade possible. So what that means is, despite all its fascinating complexity, the clinical outcome is excellent, especially if the surgeons are able to get it all out. And that solves the clinical mystery of the papillary glioneuronal tumor. But it kind of leaves us with a much bigger question, doesn't it? By figuring out the precise genetic typo that can make two totally different brain cells grow together like this, what else can we learn about the fundamental rules that govern our brain in the first place? It's a pretty amazing thought. Thanks for joining me on this one.